This is Chapter 5, Drugs Affecting the Cardiovascular System. So we're going to go back through just a brief anatomy and physiology of the heart. Remember, there's pulmonary and systemic circulation. So pulmonary circulation is going to come from the right side of the heart. By the right atrium, blood's going to go past the tricuspid valve into the right ventricle. Right ventricle is going to be pumped out past the pulmonary valve to the pulmonary artery, and then it's going to circulate into the lungs. It's going to be brought back to the left side of the heart through the pulmonary vein, and it's going to enter into the left side of the heart at the left atrium. And that would be your pulmonary circulation. Your systemic circulation starts over there on the left side of the heart at the left atrium, goes past the mitral valve into the left ventricle. Left ventricle contracts, goes past the aortic valve out to the aorta. And then from the aorta, it's going to circulate out to the rest of the body through the arteries, and then arteries into the capillaries, capillaries back into the veins, and then the veins are going to enter the blood to the cranial and caudal vena cava and enter back into the right atrium. Controlling the heart and the beat is going to be the electrical conduction system through the heart. And a brief review of what a heartbeat will look like. On a tracing of what's known as an ECG, we're going to have a P wave, a QRS, and a T wave. We see the P wave whenever the atriums contract. The QRS is going to be when the ventricles contract, and then the T wave is going to be when the ventricles repolarize. So we have the SA node right here depolarizing, and that's going to start your P wave, and you're seeing this whole P wave right here as that electrical impulse goes across both the right and left atrium. Also within the right atrium is going to be the AV node, and the AV node is actually going to take that signal and it's going to pass it on to the ventricles, because there is no direct electrical conduction from the muscles from the atriums to the ventricles. It's actually going to be done through this AV node in something here called the bundle of His. And so somewhere in this P wave is when the AV node gets the signal from the muscles of the atrium, and it kind of holds it for a slight delay, and then it's going to actually send that signal down the bundle of His. And once it passes out the bundle of His, it's going to go to what we know as bundle branches or Purkinje fibers. And so whenever these Purkinje fibers are first depolarized, that's when we're going to see our Q here on our QRS. And so this is when the ventricles start to depolarize. So when we see the Q, it's going down the Purkinje fibers, and then all at once we have the big R, and then down here the S, and then that's the whole electrical wave going across the ventricles. The ventricles have much more muscle mass to them compared to the atriums, if you remember that from anatomy and physiology. So your P wave is always much shorter than your QRS, and your QRS is much larger because of all the muscles in the right and left ventricles. And then there'll be a slight pause here, and then we see the T wave, and this T wave is actually when we're going to end up having the ventricle repolarize. We don't actually see electrically the atriums repolarize, and remember that's because it's going to be hidden right here by the QRS complex. This whole QRS complex right here is very well synchronized through the Purkinje fibers to make sure that the ventricles beat in a specific direction. We have one P to one QRS complex to one T. Remember, that is going to be a sinus rhythm. And any alterations to this would be what we would call an arrhythmia. There is no direct nervous input into the SA node. However, the sympathetic and the parasympathetic nervous system through various hormones do have an effect on the SA node and the heart in the way it's going to be. Starting off with the sympathetic nervous system, this is going to be our catecholamines, things like an epinephrine, norepinephrine, and dopamine. And they're going to actually attach to beta-1 receptors. These are also known as adrenergic receptors. We have alpha-1, alpha-2, beta-1, and beta-2. And so beta-1 is cardiac, beta-2 is arterioles and bronchioles. And so our catecholamines have mostly beta effects on beta-1 and beta-2. They can have some effects on alpha-1 and alpha-2. The big thing is when they stimulate beta-1 is we get an increase in the rate of the heart, so it speeds it up. And it also increases the force of contraction. It makes the muscles contract much stronger, and so it actually increases the contractility or the force that the heart actually pumps blood out. If you've ever been startled and you feel your heart race and it feels like it's beating really hard in your chest, this is an effect of beta-1 and will be seen with a fight or flight response of the animal. Parasympathetic, on the other hand, this is the rest and digest side. So these are cholinergic receptors, and most specifically is going to be the muscarinic receptors. And these, on the other hand, whenever acetylcholine actually triggers a muscarinic receptor, This actually causes the SA node to slow down the heart or decrease the speed and not beat quite as forcefully. So it actually causes both the slowing and a reduction in force of the heart. And so this is what you usually feel when you're at rest. There is this constant tug of war between our sympathetic and parasympathetic nervous systems as the different ones are triggered throughout the day, and you're going to see an increase in the heart rate whenever the sympathetic is engaged, and this could be for something like being frightened, but it can also be engaged when there's like exercise going on. There's an automatic up rhythm and sympathetic input to that. And then whenever exercise is stopped or whenever our patients are relaxed, then the parasympathetic is going to kick in and slow that heart rate back down. So anytime that we have an alteration to the normal rate of the heart, so it's going either too fast or too slow, or we have a change in our ratios of P waves, QRS, and T waves, so if we start missing P waves, if we start having changes in the shape and the form of our QRS complexes, these are things that are known as arrhythmias. And so we have a lot of drugs that work specifically on arrhythmias, and we classify them as either a class 1, class 2, class 3, or class 4 antiarrhythmic drug. And this is going to be based on their mechanism of action or how they actually work. So class 1 antiarrhythmic drugs are going to be the sodium channel blockers. And what these do is they actually block the sodium channel and they slow down depolarization. And by doing that and slowing down depolarization and the rate it happens at, you're going to slow the heart rate. And it actually will stabilize the heart if the heart rate is too fast. Or if we start having issues with what we call ectopic ventricular rhythms. So this is when the ventricles just start to beat on their own independent of the atrium. Our big drugs in this area are going to be drugs like lidocaine, quinidine, and procainamide. Lidocaine is the one that we use most often in emergency situations, so we have a really, really fast, unstable heart rate. We can do a bolus of lidocaine followed up by an infusion. Lidocaine is also a local anesthetic, and what it does to the nervous system is the same thing. It actually will sit there and it slows down and blocks those sodium channels, and so it changes the way that the body actually feels and perceives, and so it ends up being a local anesthetic in areas. And it does the same thing for the heart when we use it systemically. We've also used procainamide quite often in veterinary medicine also, and these are usually used more in the emergency and acute situations. Long term, we would be using something like mexilentine as an oral medicine to keep doing what lidocaine or what procainamide would do. Class 2 antiarrhythmic drugs, these are going to be what we know as the beta blockers, so they actually are going to block the effects of beta 1. And by blocking the effects of beta 1, you would slow down the heart rate. So a lot of times if we have fast heart rates or ectopic heart rates, we will use these drugs more in the long-term maintenance category. We can potentially use some of them in the emergency, but usually it's after we get the heart stabilized, we can use the beta blockers to stop the arrhythmia from occurring and do this over a long period of time through giving these medicines. And the big thing that it does with these beta blockers, once again, is we're going to use these on really fast heart rates or these ectopic heartbeats. And they're going to work by blocking the effect of beta 1 and the sympathetic stimulation of the heart. Some of the different arrhythmias we can do is our ventricular tachycardias, but also some of our atrial arrhythmias too. And we have used them for things like atrial fibrillation or atrial fibrillation with rapid ventricular rate, or what's known as RVR. Drugs in this category are going to be like propranolol, metoprolol, are probably the main ones that we use. And sometimes we actually use altenolol also. Class 3 are our potassium channel blockers. We don't use these that often in the veterinary medicine. They're used way more in human medicine. But these will work by actually inhibiting the potassium channels, kind of doing the same thing that the sodium channel blockers do. It actually prolongs repolarization periods, slowing down the heart rate. We've used these for specific ventricular arrhythmias, and especially our ventricular cardiomyopathy in boxers. And we can use these as a maintenance drug, and we can also use them in the acute emergency situations. Sometimes, especially with boxers in ventricular fibrillation, drugs like amiodarone will be much more effective at actually stopping that arrhythmia in those dogs. And we have used sotalol and amiodarone specifically in boxers as a long-term medicine to stabilize certain arrhythmias. Lastly, our class 4 are going to be our calcium channel blockers, and so these actually slow the calcium channels from releasing calcium within the cardiac muscle. Main drug here is going to be verapamil. We use it with caution because there is a lot of cardiac side effects in our patients. I use it somewhat also in caution in people, making sure it's the proper arrhythmia when we use them. And probably our biggest arrhythmia that we will use it for would be like an unstable atrial fibrillation or atrial flutter. Once again, it's a very limited use that we use these drugs in veterinary medicine. Sometimes what we're needing to do is speed up the heart, maybe make the heart start beating again if it stopped for some reason, or we need to actually increase the force of contraction. And for this, we use our catecholamines. And so these are going to be drugs like norepinephrine, epinephrine, and dopamine. And so these are the drugs, once again, that would mimic or be doing the exact same thing that the sympathetic nervous system does. And so they're all going to be based on the natural positive ionotropic drugs in the body, or hormones in the body. So they increase the heart rate, they increase the contraction of the heart too at the same time. And there can be some side effects when we use these drugs, such as jitteriness or heightened alertness, sometimes a fight or flight response of the body. Where we use epinephrine and norepinephrine most of the time ends up being for when it comes to the heart. When it comes to the heart, most of the time we're going to be using these drugs if the heart is not beating either strong enough or not at all. So in the case of CPR. Dopamine we usually use in the form of a drip, and its main thing is it doesn't really speed up the heart as much as epinephrine or norepinephrine does, but we end up using it instead to actually increase that force of contraction without necessarily making the heart rate go up that much faster. A drug that would mimic what dopamine does is dobutamine, and it has a lot of the same effects that dopamine has, and at the same time it also has an renal effect. So it actually will increase renal output of urine. Pimobendan, known as vetmedin, has been used as a vasodilator and positive ionotropic drug for a lot of our dogs that have congestive heart failure. So it reduces resistance by relieving vasoconstriction, and at the same time it actually increases contraction of the heart. And vetmedin has been used a lot more since it came out on the market probably about 10 or 15 years ago, and started to displace the use of digoxin, and it's been made specifically for dogs. Digoxin is probably still the most commonly used ionotropic drug. However, vetmedin has a lot less side effects in our animals than what digoxin does. So digoxin works very good as a positive ionotrope. However, there are a lot more side effects and arrhythmias that come along with digoxin versus vetmedin. For some of our conditions, we need to work on vasodilating and vasoconstricting. So what we're trying to do is, a lot of times with animals that maybe have congestive heart failure or hypertrophic cardiomyopathy, we can have a lot of vasoconstriction going on that puts a lot of extra workload on the heart. And so we will use these vasodilator drugs to actually cause that vasoconstriction to go away and actually lower the blood pressure overall in the patient, and it actually makes it easier for the heart to work. So we start looking at vasodilators. We have three different classifications. We have pure arterial vasodilators, so these work just on the arteries and causes them to vasodilate. We have pure venodilators, so these work just on the veins and cause them to dilate. And then we have mixed vasodilators, and they actually do an equal balance between both arterial and venous dilation. All the drugs have an effect on both arterial and venous side, but usually our pure arterials work much more on the arteries, where our pure venos work much more on the veins, and our mixed work evenly between the two. So the arterial vasodilators are going to work mostly just on the arterial side, and then what they're going to try to do is reduce arterial constriction, especially from around the heart, and make it much easier for the heart to pump blood out into the lungs and out into the aorta. And we do this with animals that we know we have hypertension in due to some type of heart failure that's going on. And so we can use amlodipine, which is also a calcium channel blocker. And then much more commonly used is hydralazine, because it works specifically on the smooth muscles in the arteries to relax it, and doesn't have some of the other calcium channel blocking effects of the amlodipine. Our primary venous dilator has been nitroglycerin, and so nitroglycerin has some artery effects, but most of its effect ends up being on the venous side of circulation, and so it causes really good venodilation. In the pulmonary system, it has about an equal pulmonary artery and pulmonary vein dilation, but in systemic, it's pretty much more on the venous side. It also dilates all the vessels within the coronary arteries. And so in humans, they use this a lot for a condition called angina, which is where we get constriction of the arteries and the veins in the heart that causes chest pains. And nitroglycerin actually dilates all the myocardial blood vessels and can relieve that angina pain. Big thing to know about nitroglycerin is it has a very short half-life because it's rapidly metabolized by the liver and has a very high first-pass effect of the drug. Usually when we end up using this drug on the veterinary side, we're using either a transdermal patch to where it's continuously released into the bloodstream, or we're using a topical cream that's applied. And most of the time with a topical cream, we're working on a specific area we're trying to venodilate, such as like a horse with laminitis. If we're trying to venodilate the blood vessels down in the hoof, we would actually put the topical ointment on the palmar digital arteries and veins to actually get it down into the foot to cause that venodilation there. Most of the time, to actually treat most of our conditions, we use mixed vasodilators. And so they're going to have an equal effect on both the arterial side and the venous side. A cousin to nitroglycerin is nitroprusside. And we've used this most of the time as an emergency drug for animals in severe respiratory distress due to pulmonary edema or pulmonary hypertension secondary to heart failure. For long-term maintenance of animals, we use a lot of what we call ACE inhibitors. So these are going to be angiotensin converting enzyme inhibitors. If you remember, renin is made in the kidneys in response to low blood pressure. Renin travels to the liver where it's going to be converted to angiotensin 1, and then angiotensin 1 is converted to angiotensin 2, and the liver releases angiotensin 2, which goes out to all the different blood vessels in the body and actually causes both arterial and venous constriction. So it causes vasoconstriction across the body, and this is the main way the body actually sits there and regulates blood pressure. So we use drugs like lisinopril or enalapril, and these actually relax the smooth muscle in the arterioles and the veins across the body, and they reduce blood pressure. Once again, we use this a lot in our animals with congestive heart failure. A lot of times what we have happen with our patients is they get a buildup of too much fluid in their body secondary to congestive heart failure. And to actually treat this, we end up giving them diuretics. And so we have different classifications of our diuretics. We have loop diuretics, our thiazide diuretics, potassium-sparing diuretics, osmotic diuretics, and our carbonic anhydrase inhibitors. And all diuretics are going to cause the kidneys to increase urine production and remove that extra fluid from the body. Our loop diuretics are going to work at the loop of Henle. So if we go back to anatomy and we look at the kidney and we look at a nephron, remember the loop of Henle is going to be down in the medulla of the kidney, and it's going to be very important in reabsorption of water and of different electrolytes like sodium, potassium. So a loop diuretic works on the loop of Henle, and what it does is it blocks reabsorption of water. Along with that, it also happens to block some reabsorption of sodium and, more importantly, potassium. And we don't lose nearly as much sodium from loop diuretics as we do potassium. So anytime we use a loop diuretic, we always want to monitor potassium levels with them. Loop diuretics like furosemide, commercially known as Lasix, has been extremely successful at actually removing excess fluid from the body, and it's our main go-to diuretic drug. We have our thiazine diuretics, so these actually work a little bit differently. They work in the distal convoluted tubule, where once again we get sodium, chloride, and water reabsorption, and they block the reabsorption of water and along with it sodium and chloride. Really doesn't cause that much disturbance with electrolytes and really doesn't have as much issues and impacts on potassium as say our loop diuretics. However, they're not always quite as effective as our loop diuretics. So in our milder cases, a lot of times we'll try with things like chlorothiazide or hydrochlorothiazide in place of furosemide. We have potassium-sparing diuretics, so spironolactone is the main one that we use. We usually use it in conjunction with our loop diuretics, and what it does is it actually increases the reabsorption of potassium back in the body, so we don't have that dipping down or that major loss of potassium that we see with our loop diuretics. Osmotic diuretics, this is going to be mannitol, which is a very complex sugar that draws fluid to it. and then it is very easily removed from the body and not reabsorbed through the kidneys, thereby taking the water along with it. Most of the time when we use our osmotics, this is going to be for edema in the body, so we can use it for pulmonary edema or cerebral edema. We don't really use it more for a long-term maintenance use. It's more for a short-term medical treatment. Lastly, we have our carbonic anhydrase inhibitors. This is acetylzolamide. Can be used as a diuretic, but it's not the strongest diuretic, and so we don't really use it that much in veterinary medicine. It's fairly weak as a diuretic. We use it more as a glaucoma treatment because it works very well in treating glaucoma and decreasing intraocular pressure. But for some cases where we need to use a mild diuretic and we're not really needing one that's potentially that strong, we can use acetylzolamide. Lastly, we come to other drugs that we use that have an effect on the cardiovascular system. And so one of the main ones we use is the NSAID aspirin. And so a big thing that aspirin does is it inhibits platelet aggregation, thereby actually stopping clot formation from occurring. And so we use them as what we call blood thinners. And so we can use aspirin and drugs like it, say trying to stop the formation of a thrombus from something like hypertrophic cardiomyopathy. It's used quite often in the treatment of laminitis in horses, trying to keep blood from clotting in the hooves and further making the condition worse. Big thing to know with cats, if we do use it for something like hypertrophic cardiomyopathy, is that we have to be cautious with the use because cats do not metabolize NSAIDs the way that they should or appropriately, and it's very easy for them to build up a toxic level. Lastly, we can use sedatives and tranquilizers sometimes in animals that are really anxious to slow down the heart rate. So we have an animal that comes in and their heart rate's really fast due to anxiety. We can use drugs such as acepromazine, dexmedetomidine, or xylazine, and actually through the sedation and slowing down the heart rate, we actually reduce the heart's overall consumption of oxygen and other nutrients that it needs, and it reduces the workload on the heart overall. Of course, anytime that we sedate an animal or we tranquilize them, there's other risks that do come along with that, and so we do have to weigh the side effects of the sedation or tranquilization going to have other effects that would be negative on the body and other adverse reactions. So that is Chapter 5, Drugs that Affect the Cardiovascular System.